Thank you, Sahani sir. Good evening, good afternoon, and good morning. This is the 1845th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guests are homeopathic lovers, students, and doctors. And today we have a panel discussion. Let us begin the session with 1 minute silent prayer. As you all know, the International Forum for Promoting Homeopathy comprises of homeopathy lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself so that those who missed the session can watch it again, and you can share it with your friends. As the purpose of this forum is to take homeopathy to every home around the world. And as you all know, the International Forum for Promoting Homeopathy is celebrating its 5th anniversary on 28th September at Touch Vivanta Cochin. Hope all of you will register for the same. We have, there are a lot of short presentation, discussion, interaction with the students, and question answer session for students, and there will be presentation on dental homeopathy, veterinary homeopathy, and agro homeopathy, and at the end there will be some cultural programs too. Please support us with your registration, rupees 3,000 per person, and there will be those who are unable to come here can contribute a sum of money for the success of the session. Thank you all. It's over to Dr. Shedar Singh to begin as the moderator. I am inviting Dr. Shedar Singh. As you know, she is the associate researcher at Center CCRH Delhi, and she is the chief consultant at Orbit Clinic. So over to Dr. Shedar Singh to moderate today's session.
Thank you so much, sir. Thank you, Dr. Danish and Dr. M.K. Sahani, sir, for inviting me to moderate this session. And today's panel discussion focuses on a theme of utmost importance, that is challenges of research in homeopathy. The topic holds great importance for both students and practitioners. For students, it provides clarity on how scientific evidence strengthens learning and practice. For practitioners, it highlights the need to adapt, innovate, and validate clinical experiences through research. And understanding these challenges bridges the gap between knowledge and application of medicines, ultimately advancing the future of homeopathy. So we are privileged to have with us our distinguished panelist. Let me introduce first Dr. M.K. Sahani, sir. Theory becomes reality with the practical. In Dr. M.K. Sahani, sir, one can observe him trying to convert theory in practice and simplicity at heart. He accepted only that philosophy which he could prove in practice. Thus, Dr. Sahani became a meeting point of both spiritualism and materialism. His long journey in teaching accumulated as vast storehouse of information, finally elevating to the authoritative level of professor. With his deep interest in homeopathic philosophy and ambition to visualize in practice, he mastered in repertory, materia medica, and homeopathic philosophy. He's popularly led him to be elected as a member of Central Council of Homeopathy, where he was serving as chairman of the education committee. And he's popular among his patients, for whom his caring heart experiences the pain and misery, giving solace to them. And his patients are distributed in and around the globe. He's now accepted as expert, and patient are referred to his expert opinion. Our next panelist is Dr. A.K. Gupta, sir, founder, director of AKG's OVHUMS, Om Vidya Institute of Homeopathy and Allied Medical Sciences, accredited in Limca Book of Records, pioneering integration in healthcare, National Secretary General of the Homeopathic Medical Association of India, HAMAI, former visiting professor in Dr. B.R. Sur Homeopathic Medical College and Hospital, Delhi, ex-guest professor in College of Homeopathy, UK, guest physician, Glasgow Homeopathic Hospital, Glasgow, UK, Practicing since 1977 and former nominated member of Homeopathic Advisory Committee and Delhi Board of Homeopathic System of Medicine, Government of Delhi, doing special research work in cases of MND patients and recipient of many national and international awards. Our next panelist is Dr. Kulwant Singh, DHMS, MD Homeopath, from Rajasthan Vidyapeeth GD Memorial Homeopathic College, Patna. He's the ex-principal of Singhbham Homeopathic Medical College and Hospital, Jamshedpur, since 2000. Teacher since 46 years and faculty of Homeopathy, Vinoba Bhave University, Jharkhand. Ex-chairman Homeopathy Literature Committee and Education Committee, CCH, New Delhi. So I welcome all of you to today's panel discussion. And my first question is to Dr. M.K. Sahani, sir. So given that homeopathy emphasizes qualitative symptoms, how can we quantify such data without distorting its meaning?
This is a great question, Dr. Sweta. In actually, the value of symptoms lies in not only its intensity, but also on the uniqueness. It is strangeness, rare and peculiarity in homeopathy. Then traditional biomedical research often reduces symptoms to number, but in doing so risk striping away, and to solve this, we need a dual layer of the data capture. The layer will be quantitative capture. Then you record the exact words of the patient, including emotions, tone, metaphors, and body language. And because they convey the essence of the symptoms. Then second layer, you go to the quantitative as translation, applying a structured scale like Likert scales, visual analog scales, or numeric grading that we are presently doing to rate the severity, frequency, and duration. For example, a patient says, I feel a cold wind going through my bones even when I am indoors. Now, what is the qualitative feature for this? Peculiar sensation, modality better from warm, imaginary wind through the bone. This is the imaginary, all important for reporterizations. Now, qualitative, VAS 8/10 for severity, occurring 3 to 4 times a day and lasting 30 minutes episodes. So, benefit lies in the preserve the meaning of for the remedy selections, while a quantitative side allows the statistical comparison in research. So tools like outcome in relations to impact on daily living, then the modified Naranjo criteria for homeopathy. These are all tools are available. For example, to validate framework for this data dual capture. Then likelihood ratio is also important that we should try to understand well. So thank you.
Thank you so much, sir. And my next question is for Dr. A.K. Gupta, sir. So how can clinical case records from long-term practice be transformed into publishable research without losing the essence of individualization?
Dr. Gupta, we are not able to listen. You have to unmute yourself. You unmute yourself, Dr. Gupta.
Yeah.
You can start.
Can I share a few slides with that?
But if it is it should be short because.
No. I'm just putting the basic of that. The heading is there.
You can do it. You can do it.
Where is it? Share. Is it there?
Not open yet. It takes time, sir. So yeah, I think you go by the.
Okay. Well, we can remove that. Well, as such, you've been talking about the individualization being the main point of homeopathy, which is, I would call it, it is a boon as well as bane.
whenever we talk about the homeopathy, the first part comes about the individualization. And when we talk of the research, the way the research is being carried out up till now by the standards of ICMR and all that, according to me, what I feel is not the correct way of going for research in homeopathy, because when the like there are it is something like that, you've been asking different animals to climb a tree and see who's the best, in which comes the one who are like monkeys, like dog, like camel, like fish. If all these are being asked to put it in this and show their efficacy in climbing the tree, I'm sure they will not be able to do the justice, because monkey would be able to excel in that, but fish who's not, I mean, for that, meant for that, will not be able to do that. And similarly, camel will not be able to do that. What happens in homeopathy, when we talk of research, research has to be done on the individualized basis. When we are taking up a cases for research, all cases given arsenic album for and trying to do the research for asthma, and out of 100, only 2 patients were of arsenic. So certainly 98% patient will not show the result in that, and the actual result would come out in the form of the non-efficacy of arsenic, which is the main problem, which I think that, I mean, our CCRH people as well as the community homeopathic fraternity should put forward, that first of all, we need to individualize the patient and see that he is arsenic. All 100 patients of arsenic are given arsenic, and then only we can see how much is the efficacy of that arsenic in asthma patients. And then only we can be able to, I mean, draw this inference, the efficacy and all that. And once we have seen that, then making it to the publishable, how can we can publish? Issue is homeopathy emphasizes treating the individual, not just the disease. Each patient receives a different remedy for the same diagnosis, making standardization difficult. So this is one basic aspect for from the other system of medicine where we're doing the research. Impact, this creates challenges for randomized controlled trials, RCTs, which favor uniform interventions. Issues, homeopathy often measures success based on qualitative outcome like general well-being, energy levels, emotional balance, etc. These are hard to quantify, standardize, and analyze statistically. Now, the placebo effect criticism is also there. Critics often claim homeopathic remedies are placebos due to extreme dilutions. Now, impact, this reduces the perceived legitimacy of homeopathy research and creates bias in publication and peer reviews. Now, lack of funding and institutional support, limited funding compared to conventional medicine, fewer large-scale studies, limited access to research infrastructure, and documentation inconsistency. Issue may have homeopaths maintain detailed but non-standardized records, difficult to aggregate or compare data across practitioners, transforming clinical case records into publishable research to preserve individualization while achieving scientific rigor, or a few strategies are to be made. Use of case studies, case series, and case reports. Then utility would be demonstrate the value of individualization, can highlight the patterns of remedy selection and outcomes. Suitable for journals that accept the qualitative and descriptive research. Homeopathy journals of evidence-based, like we always look into that, and use validated outcomes measures, for example, VAS, visual analog scales or SFS 36 item surveys, apply guidelines of case report guideline for the structure. So if we follow these steps, then probably certainly we can put this individual research into publishable also. How to help computers? We need to have the data, like we are at individual level, we have been having data, but there is no uniformity. And once we have, like I have got my, in my clinic, Dr. Sahani has got in their clinic, Dr. Shweta has got, Dr. Kulwant Singh has got their own records. But uniformity of records are not there, which needs a compilation and to show as far as the publication is concerned for the published. And if we publish the same kind of data, same kind of reporting from all over, then it will make a definitely a compendium of good selective articles or selective cases, which will authenticate the research work also. So, and we need to, like the computers and all that, we have to use those software where we need to add the kind of a result, because it is not every case is being seen with the pathological reports being better or so. When it is subjective, those things have to be really taken into account with the form of data as well as with the form of photography or for the video evidence also. But certainly we can use these things for publication also. And but individualization, as said, it's a boon and bane for both ways. So now it all depends how we take it. Thank you.
Very well said, sir. We should make some standardized case record formats in our clinics, and also we have to collect the supportive material to publish our case records, definitely. And my next question is for Dr. Kulwant Singh, sir. So how can we convince policymakers and funding agencies that investing in homeopathy research has public health value?
Good evening, everyone. So there are a few points I would like to stress upon. The first is that we must recognize the heavy burden that the chronic and lifestyle diseases like diabetes, arthritis, skin allergies, there are so many of them, they are putting pressure on our healthcare systems. Millions of patients seek long-term relief, yet many remain dissatisfied with conventional options. Homeopathy is already being used by large populations worldwide. By supporting research, we can evaluate its role in easing this burden, possibly reduce healthcare costs, and while expanding treatment choices. Next point is, homeopathy offers a model of cost-effective and accessible care. That is a very great USP for us to convince the policymakers to help and to come forward to add something to this science. Its medicines are inexpensive, rather cost-effective, safe, require minimal infrastructure, which makes them especially valuable for rural and undervalued communities. If research confirms these benefits, your investment, that is the investment from the policymakers, will directly strengthen primary health care and reduce dependence on costly hospital-based treatments. This should be our USP, research with cost effectiveness, as far as convincing the policymaker is concerned. Next point is very important, that we cannot overlook that the fact that citizens themselves are asking for this. Surveys repeatedly show strong demand for homeopathic care as patients appreciate its gentle approach and fewer side effects. Supporting research in this field means responding to public needs and ensuring that healthcare systems truly reflect patient preferences. This patient preference is very important, at what the patient wants. The patient wants cost-effective, patient wants the treatment which is not having so many side effects. Patient wants the treatment or the pathy which can almost cure the disease, not palliate. So these are the things. If we propagate our pathy properly, this builds trust and strengthens the bond between policy and people. It helps to integrate safe, evidence-based, and complementary methods. This should be our focus. Next point is that homeopathy has great potential within an integrative healthcare framework. It does not replace conventional medicine, but complements it. We should stress on this. We are not replacing you, but we are complementing you. Because there is a lot of negative publicity, negative opinion about homeopathy in modern science doctors. So gradually it is reducing by our evidence-based practice, by the government support. It is reducing, but it is still prevalent. So it does not replace conventional medicine, but it complements it. Through evidence-based research, we can define where homeopathy is more effective, whether in prevention, whether in chronic disease care, or whether in supportive treatment. This integration allows doctors to combine the strength of both systems, ensuring better outcomes for patients. I'll give you some examples, like there are very, very regular cases of hypothyroidism which come across us. So normally in my practice, I do not stop altroxin or thyroxine or thyronorm immediately. So the patient is also happy that the patient continues with thyronorm. We supplement with our medications and gradually we reduce the thyronorm. And in the long run, the patient becomes solvent. So in this manner, we are complementing them. I know Dr. Gupta, Dr. Sahani, all are senior physicians, and they must be also doing like this in their practice. Next point is that by funding, we should convince the policymakers that by funding homeopathic research, we show global leadership and scientific openness. Countries like India, Germany, Switzerland, and so many other countries are there who recognize and who help homeopathy also. But there should be a proper research, which Dr. Gupta was telling. I completely agree with him that with proper records, proper formats, and the most important, proper sharing. The sharing part we are lacking. So proper sharing should be there. And one very important thing which is related to Dr. Gupta's comments also, that we should focus on patient-reported outcome. It is known as PRO. Patients' reported outcome should be recorded in a proper scientific manner, which can be presented in several seminars, NGO meetings, government organizations, that these are the proof where we accept. Because our most important drawback is that no experiment has shown that how homeopathic medicine is working scientifically, clinically, but clinical evidence is there, and we should focus on that one. That part which should be our USP, patient reported outcome. And one more thing, I would request all my physicians, colleagues, that concentrate on your core sector. Homeopathy, every science has got its own limitations. So we should concentrate on our core sectors where we are very sure that these are the parts where homeopathy acts very nicely. There are some red flags. There may be some red flags where homeopathy is not very effective. So don't concentrate on that, wasting your energy. You can try, but focus on your core sector so that the society, so that the government, so that the educational system, so that the medical system are convinced that we are able to do something. And of course, Dr. Sahani and Dr. Gupta told there should be evidence-based research, multidisciplinary research, to strengthen scientific review. Thank you.
Very well said, sir. And my next question is to Dr. Sahani, sir. Sir, what are the limitations of applying conventional biomedical research models like RCTs to a system that thrives on individual prescription?
Now that we as a homeopath believe in the individualized system of medicines. And for this, the randomized controlled trial, which is designed for intervention where every subject in the treatment group receives the same standard drugs at the same dose for the same conditions. But in homeopathy, however, follows the dynamic individualizations, like the two asthma patients are there, one may receive the natramyr sulfuratum or other will the calicarbonicum respectively, based on their uniqueness of the symptoms. So I recall my thesis defense process during the our PhD examinations, where my examiner was the pro-VC of the university, and he asked me, you have provided different medicines for each one of them. So how it is possible? Then I explained to him about these things. Then he was not convinced initially, but later on we made him convinced that this is. So he suggested that the best way to make research should be the case series studies. However, now that since the uniqueness and the challenges for the RCT trials are important, is required to compete with the other system of the medicines also. So we have to we have to find out the challenges. That first challenge is non-standardized interventions. That is impossible to give the same medicines to all the participants without violating the core principles of the individual. And the second challenge is outcome measures, major mismatch. So biomedical research focus on the disease parameters in like FEVI in asthma, while homeopathy also value the subjective changes like sleep, emotional states, peculiar symptoms, which may not be reflected in the conventional makers. Then sample size issue. This is also a strict inclusion criteria for the RCT are often leaves a very small participant pool for individualized participants. Now, during my coordinator for the PG students, the protocol that we used to have the inclusion criteria and every students who are coming with the 30 students, 30 participants. Now, why? Because they are finding it difficult in having those. So they have created, and I think it is being followed all over the country nowadays. Then next is the ethics concern. Then placebo groups in chronic illness might suffer prolonged discomfort if individualized remedies are withheld. Then time frame is also important. Homeopathic improvement often takes over a month, conflicting with the short trial durations. So now the alternative models that we can suggest and we can look for is the N-to-1 trials. Each patient acts in their own control over the time. That sounds similar to the case series study. Then pragmatic clinical trials, and then where we evaluate the treatment as practiced in the real life. And then observational cohort studies track outcome without rigid interventions and standardizations. And last point, alternative, the adaptive trials, like modify study protocol patterns for the emerge. I think CCRH is also developing some type of the model for the specifically for the homeopathy. So I feel that this RCT should be there, but it should be done. It should be based only. It should be friendly with the homeopathic principle. So So I can say that by using such flexible design, we can respect the homeopathy. This is a very important for us. We should not deviate from our principle. And otherwise, there will be no importance for the homeopathy. So generating the scientific data, validity data, and respecting the homeopathic principle, this is one of the greatest challenge. And I feel that the above concerns can be answered and solved in coming futures. Thank you.
Yes, sir, definitely. I agree. We should not lose the uniqueness of homeopathy and the principles of homeopathy. And my next question is to Dr. A.K. Gupta, sir. Sir, in real life practice, patients often use multiple treatment modalities together. So, how can research isolate and evaluate the effect of homeopathy alone?
Well, this is a thoughtful and important question, especially in the context of evaluating treatment. Treatments like homeopathy, which are often used to as part of a, broader complementary or integrative health approach, as Dr. Kulwant Singh has rightly mentioned. The challenge with the real world use is versus controlled research. Now, that is the point where we have to look into that. In real world settings, patients frequently use multiple therapies simultaneously. For example, combining homeopathy with conventional medicines, lifestyle changes, supplements, or other alternative treatments. This makes it difficult to isolate the specific effect of any one component, including homeopathy. Now, this is what we call it. Sometimes, it's especially in our country, India, patients are so impatient, they want a quick relief, so they would not mind, like I'm treating, a lot of MND patients, so they take allopathy also. First of all, they go to allopathy, who they tell them there's no treatment, then they start looking for some other systems. And allopathic is there, homeopathy is there, they try Ayurveda also there. It's a khichdi of kind of a thing. So which makes it sometimes very difficult to assess what has been affecting. At the end of the day, what I feel in my practice, personally, I'm sharing that only. I tell them, if you are taking any particular medication, if it is helping you, then you please can carry on. If you have been taking it for the last 6 months or 1 year, if you find that it has not affected you at all, then you can suspend it, come totally on one system of medicine, be it homeopathy or be it anything else. So then we'll be able to, see the difference and appreciate the efficacy of homeopathy. Otherwise, what happens is, sometimes you feel better after homeopathy, but नहीं तो मैंने एलोपैथी ले रहा था, उसकी वजह से फर्क आया. So this causes a problem. How research attempts to isolate the effect of homeopathy. To evaluate homeopathy alone, researchers use several methods designed to control for confounding factors. That is, randomized control trials, RCTs, designs should be participants are randomly assigned to receive either homeopathy or placebo or another comparator, for example, conventional treatment. One double-blinded, meaning neither the patient nor the researchers knows which treatment the participant is receiving. Goal is isolate the specific effect of homeopathy by comparing outcomes to placebo or standard care. The strength would be high internal validity, good for determining the causal relationship. As I told initially in the beginning, we need to, as a doctors, our main aim is the welfare of the patient. Earlier, what it used to be, like if, being fanatics or being, orthodox, if you are taking allopathic and coming to homeopathy, doctors used to say, stop allopathy completely, as Dr. Kulwant Singh has said about the thyroxine and all that, the patient who has been taking for a long term. So if we ask them to stop taking thyroxine or Tylenol, the patient will have into, more problem. So instead of doing good for the patient, we might, give a problem to the patient. Those who are on I mean, CKD patients having long-term medication. So we need to give our medication, which is homeopathy, is going to boost up the vitality. And I have seen in my practice that there are patients who have been taking these allopathic medicine for maybe diabetes or blood pressure and all that, and it has stopped affecting them anymore. And that is the time when they come to homeopathy, and what I give is we give the medication, and after giving the constitutional treatment, now this is the very important part, they have been taking the medication for their disease. Once they come to a homeopath, we give the medicine for that particular patient who is having that disease. So that stimulates his vitality, his or her vitality, and that makes that particular patient again start responding to the same medicine which had stopped. So that is the beauty of homeopathy. As we've been talking about, as a complementary or as a individual medicine, it is very good. But those cases where the patients have been taking therapy medicines are there, multiple drugs are there. So we need to see, first of all, they should not counteract each other. If, we can know something about it, what medicines they are taking, we can study it out and find it out. Or the best part is we can ask them to keep a gap with the medication for half an hour to 1 hour. That is a standard which we need to follow. Now, there are limitations also, may not reflect how people are use homeopathy in everyday life, limited external validity. So this is another issue where the patient, they say, if we have taken the medicine, but we could not carry forward. And many a times, medicine given on a constitutional base and a high potency starts showing its action after certain period of time. Because I'm reminded of my early days of practice. The patient of a wart had a wart. He was treated by some homeopathic doctor, and he showed me the medicine and all that, but it did not work. And to me also the medicine was the correct one. So what I did, I just gave him placebo and thought, because the time taken by that medication to act was not there up to the level. And once that, it has acted, the wart disappeared. So the credit, instead of going into that particular doctor, came to me. So this also happens sometimes, which we need to see when the patient is taking, medication in a different manner. Now, pragmatic trials evaluate treatment under real-world world condition, allowing for combinations of therapies. Homeopathic arm, patients receive homeopathy as its typical practice, possibly along with other care. Comparator arm, patients receive usual care or another treatment, assess effectiveness, not justify efficacy, reflects real-time usage, and the limitation harder to attribute effects, specifically to homeopathy. And what we need to do is going in for as a random trial, we can go in for N of 1 trial, which gives a better understanding from homeopathic point of view. The one patient, has been taken into account, and we do the research on that. And given the, medication as per the symptoms, as per the individualization, and keeping all the principles of homeopathy, that definitely is a live case research would be better rather than giving any medication to the number. As I said earlier also, it would be very difficult to go at par the result of, qualitative medicine and the quantitative medicine. That would be a different one. Design a single patient alternates between homeopathy and placebo in a structured blinded fashion, and assess whether homeopathy has a consistent observable effect in the individual. This is how we can look into, and the personalized assessment, which is good for chronic conditions. Observational studies with the statistical controls, studies that follow patients who choose homeopathy with or without other treatments. And method certainly we can use is statistical techniques, for example, regression analysis, propensity scores, matching to control for confounders, large sample size, real world relevance. This would be need to be seen, and susceptibility to bias cannot definitively establish the causality. Compare the component of the analysis or add-on studies. Compare a group of receiving a standard treatment planned homeopathy to a group receiving a standard treatment alone. Isolating the effect of homeopathy in research is methodologically challenging, especially because it is often used in combination with other treatments. However, researchers are carefully designed trials, blinding controls, and a statistical technique to attempt to isolate its effect. This is how we can look into that. Thank you.
Thank you so much, sir. And my next question is to Dr. Kulwant Singh, sir. Sir, what collaborative research models can be developed between homeopathy and other medical systems without compromising on core principles?
See, when we talk about collaboration between homeopathy and other medical systems, it is important to remember true collaboration does not mean compromise. It means complementing strength for the benefit of patients. We must remember this. So first, we can create integrative clinical trials where homeopathy is used alongside conventional care, particularly in chronic and palliative cases. These real-world studies will respect the individuality of homeopathy while showing where integration truly helps the patient. This part we must take care and we should be very careful because this model values what matters most to the patient. That patient's faith should be there and we should be only complementing the modern systems. And it has helped a lot. The second part is that we can create integrative clinical trials where homeopathy is used alongside conventional care, particularly in chronic and palliative cases. And we need patient-centered comparative studies. You see, this is very important. The comparative studies should be patient-centered. Normally what happens, there are modern technology, there are big words, there are so many big things which nobody understands. There is a clinical report, there is a finding report, there is a research report. You go through that, you can't understand everything of it. So it should be in simple manner, it should be in understandable manner, and it should be patient-friendly. These real-world studies will respect the individuality of homeopathy while showing where integration truly helps patients. This part must be taken care very seriously when collaborating with other branches of medicine. Because it becomes very difficult to convince the other branches that there should be a joint study, there should be a joint study group, there should be something. I live in Jamshedpur, which is a very small place. But sometimes I tried with a few of my allopathic friends who were convinced of the action of homeopathy, but they were not sure how it works. The doctors were my patient, their family were my patient. So we tried to do something but could not succeed. I'm very sorry to say this. We could not succeed to come to a common formula that how a research can be done and how we can take help of the big corporates in Jamshedpur in this manner or this project. Second thing next is that we need patient-centered comparative studies. Patients care more about lab values. No, they do not care more about lab values. They want relief, they want quality of life betterment and fewer side effects. By comparing outcomes across systems, we can demonstrate homeopathy's unique role in policymakers, which policymakers can understand. I repeat, results should be there. That is the only USP we have. We can show that, you see, this case I cured this case homeopathy cured this. So there are so many difficult cases which are from our core sectors. And that results should be shown to the policymakers, whoever they may be. Next point is that we can design preventive health programs. That also is very important. Imagine tackling lifestyle disorder or seasonal illnesses with a joint approach, conventional medicine ensuring emergency readiness, and homeopathy enhancing resilience and prevention. This strengthens the communities without diluting our principles. Next is we must explore basic science research with nanotechnology, with immunology, molecular biology. We can better understand how homeopathic medicine works. I always pressurize on this, that we must try to emphasize and we must try to find out some explanation, proper explanation, scientific explanation, convincible explanation that how our medicines work. We show with clinical evidence that our medicines work. There is ample proof, ample evidence. This adds depth, credibility, and builds bridges with the wider scientific community. And finally, collaboration must extend to education. So we must involve students, colleges, doctors, research of different systems. When they learn together, the respect grows, the walls come down, and as a result, the patients benefit from truly integrated healthcare model. So collaboration is not about losing identity, it is about combining wisdom. With integrative trials, patient-focused studies, preventive programs, scientific research, and shared education, we can build a healthcare system that is more holistic, more evidence-based, and above all, more patient-centered. Thank you.
Thank you so much, sir. My next question is to Dr. Sahani, sir. Sir, how can the integration of repertory analysis and AI tools improve the scientific rigor of homeopathic research?
Great questions. This AI tools, now I feel that it has become a viral for the entire community. Even in the household work, we take suggestions from the AI tools. What should be the breakfast for today? The house bakers, they ask to the AI tools, and they will suggest you something, and they will have. So now we are becoming more and more mechanical. But the mechanizations in homeopathy is not a new phenomenon, because ever since the Hahnemannian time, this mechanization started with the repertory. He was using the repertory during his lifetime, but it was not in a published form. He had created own type of the repertory. Later on, some other form, books form, and then card form, and today we have the computer-based and software-based software. And now we find the softwares that are available, they are getting upgraded with the AI tools also, and they are in process also and in the pipelines also. So the repertory is already a semi-structured database that we understand, and of symptoms and the remedy. It is natural. It is a natural candidate for computational analysis. AI tools can build on these foundations by. Now we can use this AI. We have to be very much specific and careful in using the AI tools. That first point we should think that pattern recognitions. What AI can do? AI can analyze thousands of cases to identify patterns in remedy selections for certain clinical scenario, even across the different practices. Now the AI tools can be provided, has to be provided with the numbers of the cases, not one. So it may be 5,000, it may be 10,000. So they can give you the patterns, the line. Then second is the standardizations, that is reduced subjective bias by offering rubric suggestions based on the patient data, ensuring that two practitioners analyzing the same case don't diverge widely in their repertorizations. And this is, I think, Nowadays, it is not possible. And even with the use of the AI tools, this is not being had. So we have to standardize these aspects also. Then predictive modeling. AI can learn from large data sets to predict likely remedy outcome and compare them with the real world results. And big data analysis, like a large repertory assisted case archive from multiple clinics, that there should be I think it will be the high time for the CCRH to look for integrating and the entire, all over the country, the practitioners to allow their repertorial things, data analysis, and to share and to compile. So it can be a big task for them also. So big, large repertory assisted case archive can be prepared by, can be mined by correlations between modalities, mental symptoms, and the remedy response. For example, imagine pulling 10,000 digital data records across the multiple college. AI can tell us in case of chronic migraine with aggravations from sunlight and craving for the cold drinks, Netramute had 70% success rate across the 500 cases. Then we can have some dependency on. So this doesn't replace the human prescriber. At least even after nowadays we are relying on we are using the repertory, but repertory after the use of the selection of the remedy suggestions from the repertory, we are consulting the Medica, and then we are also using our own IQ, and this is the 3-layer. Now that can be, this AI can be utilized as. So we cannot individualize the human prescriber and provide a strong statistical backing for the pattern already observed in practice, helping bridge and credibility gap in the academic practice publications. Now, we cannot avoid using the AI tools, and we cannot stop students and others because it has become a wildfire for all over across the country and across the world. So I feel that it is the high time to think for how to integrate the and that was some of my suggestions that can be incorporated. Thank you. Yes, Dr. Sweta.
Yes, thank you so much, sir. Yeah. I have one more question to Dr. Gupta, sir. Sir, how can just a second. So, what ethical challenges arise when designing placebo-controlled trials for patients with serious chronic diseases?
Well, it is very, very important that
Yes.
designing placebo-controlled trials for patients with serious chronic diseases raises several important ethical challenges, as these trials must carefully balance scientific rigor with patient welfare, and key issue includes withholding the effective treatment. This is one. Giving a placebo instead of a known effective therapy can mean withholding potentially life-improving or life-saving treatment. So this is very, very important that when we talk of that, the research, at the cost of research, are we ready to sacrifice the patient's welfare? So this is a very ethical question which not we, but I think every community, scientific community who's also dealing with this research, look into this matter. I mean, giving a placebo instead of, this thing, pricing treatment, ethical principle involved non-malfeasance, do no harm. In diseases like multiple sclerosis, rheumatoid arthritis, or advanced cancer, a placebo may lead to disease progression or suffering that could have been avoided. Now, this is important again at the cost of what? Research and at the cost of the welfare of the patient. We need to look into that. That's again a very ethical matter. Patients with serious conditions may misunderstand the nature of a placebo-controlled trial, assuming they will receive active treatment. Autonomy, respecting the patient's right to make informed decisions. Concerns patient make consent based on hope rather than a clear understanding. Now, this is also what happens when we are doing a research without the knowledge of the patient. The patients, are being given medication. They go for the treatment, and they do not know that they are being made as a guinea pig, or they are being used as a guinea pig, and trials are being made on them. But the people, those who volunteer, now recently, we got a case from America. The patient of again MND, he was asked to join as for research. They said that allopathic, you can take homeopathy. So he said, then I won't be able to take it. I said, you can rather, this is a better method. They are doing research of their own, and you are taking along with the homeopathy. So this can give us a comparative result to show where the person are totally on modern medicine and the person on modern medicine along with homeopathy has a different rate of success. So this is where, again, it's a blessing in disguise. In certain cases we find it is better, but in certain cases where it is not been told, if the patients are not informed, it can be a very, serious issue from the patient's point of view. The ethical acceptability of a trial hinges on favorable balance between patient risk and benefits. In serious chronic disease, risk of disease progression or irreversible harm are higher, making this balance harder to achieve with the placebo arm. Use of standard of care as a comparator, and if an effective standard treatment exists, comparing a new intervention to placebo may be unethical. Best practice would be compare the new treatment to the best proven therapy, active control trials, and not the placebo, and vulnerability of the participants. Patients with serious chronic illnesses may be especially vulnerable either due to the desperation or lack of alternatives. Ethical principle justice, ensuring fair treatment and protection of vulnerable populations, and delays in access to effective therapy. Challenge could be the placebo group may experience delay in receiving effective therapy, especially if the trial runs for a longer period. Solution would be incorporate early stopping rules, rescue therapies, or crossover design on mitigate this. And scientific necessity, placebo use should only be justified when scientifically necessary. That is, when no effective therapy exists or when placebo is needed to determine true efficacy.
We have to limit the time getting short now.
Plus, okay, I think, with this, the declaration of Zelensky states that placebos should be used only when no current proven intervention exists. Thank you.
Thank you so much, sir. So as we come to close of this insightful session, on behalf of everyone present here, I sincerely thank our esteemed panelists for their insightful contributions. And your perspectives have not only highlighted the challenges in homeopathic research, but also emphasized how evidence-based approaches can strengthen our practice. And we deeply value the knowledge, experience, and dedication you have shared with us today. So thank you so much. And over to Dr. Danish.
Thank you, Dr. Sweta Singh, and for excellent moderation and very excellent discussion from our legends, Dr. Sahani sir, Gupta sir, and Kulwant Singh sir. And unfortunately, there is no time for discussion. Anyway, thank you all once again, and thank you the participant for joining the session. And tomorrow also we will have a session continuing with the same subject will be discussed by another personalities. That is Dr. Anil Kurana, former chairman, National Commission for Homeopathy, and Dr. K.C. Muralidharan, assistant director and scientist from in charge of CCRS New Delhi. And third one is Dr. Anirudh bin Sukil. He is a neuropharmacology PhD holder, and he is the director of Sugul Institute of Homeopathy and Research. Once again, a request from IFPH that we are celebrating the 5th anniversary of our continuous uninterrupted webinar on 28th September at Taj Vivanda, Cochin. Hope all of you will register for the same, rupees 3,000 per person, and those who come with accompanies can pay 5,500 only. And if you are unable to come over here, you can contribute a small amount for this purpose so that we can make it a big event. As you know, the person who is inaugurated is none other than our Honorable Ayush Minister. Thank you all. Good night. It's over to Dr. P. Shaila to moderate the Malayalam session.